The first session will be a surgical session chaired by Professor Lars Lund from Odense University Hospital in Denmark and Professor Michael Stahler at Munich University Hospital in Germany.
Thank you so much, Frede. It's a great pleasure for us to be here and open the first session to this EIKCS meeting 2021. During this session, we will start with 6 highlights from each of the panelists. I hope that you have had time to watch the presentation's video at the homepage. It's a great privilege that we have so distinguished panelists, Karim Ben Salah, Tim O'Brien, Said Dabestani, Arnaud Méjean, Maxime Tran, and Alessandro Volpe. I would like to ask you individually to present yourself and tell some highlights of your video's presentation. Could you please start, Professor Karim Ben Salah?
Thank you. Good morning, everyone, and thank you very much for the invitation. I'm very happy to be here. So my name is Karim Ben Salah. I'm a urologist working in Rennes, in the west of France, and I've been asked to talk about a comparison between partial nephrectomy and radical nephrectomy and address the issue whether or not we needed a trial to definitely address the topic of whether we should do a partial or radical nephrectomy. Should I proceed or let the others introduce themselves?
I think you should maybe say your conclusions of what concerning the partial nephrectomy. That would be nice.
Okay, so about the highlights of my presentation, the first thing that we can say when we look at the literature regarding partial nephrectomy and radical nephrectomy is that mostly what we have is observational data. We only have one randomized trial that you're all aware of. It's a very old trial, and which result had been quite surprising, showing a potential survival benefit to radical nephrectomy. But what we can say on an oncology point of view is that partial nephrectomy seems to be at least non-inferior to radical nephrectomy. So that's the main point. The second point is that there's a lot of data that goes in the direction that partial nephrectomy better preserves renal function. There's no doubt about this. The issue is this benefit in renal function preservation, does it translate into a better survival? There are some observational studies that go in that direction, but the only randomized trial that we have did not support that trend. So we don't really know whether partial nephrectomy and better renal preservation has anything. On the other side, most of the literature show that partial nephrectomy is more morbid than radical nephrectomy. And although there have been major progress with the widespread use of robotic assistance that makes partial nephrectomy much less cumbersome than it used to be, there's still a slight benefit to radical nephrectomy regarding perioperative outcomes, but the complications that can occur are quite moderate and don't seem to have a great impact on the quality of life. So, taken together, do we really need a trial? My opinion is that we don't. And partial nephrectomy is still the first recommended option to treat the small localized tumors. It's recommended by European guidelines and AUA guidelines as well as French guidelines. And do we need a trial? I'm not sure, because it would take a long time, a very long time to address the issue, a very long follow-up. And what we rather should use is a tailored approach for every patient to know, with the help of some prognostic systems that are widely available, whether we should do a partial or radical nephrectomy in a single patient. Thank you very much for giving me the opportunity of sharing this with you.
All right. I'm really impressed how deep you thought about it and how you went through literature there. We might come back to the discussion right now. We don't have questions from the audience, but in the interest of time and to go through the presentations, we'll move on and then maybe come back at the end. Next to present is Tim O'Brien from London, who actually gave a really, really nice video presentation online, and I want to encourage you all to watch it and especially get into the details. Maybe Tim, do you still do it? Cytoreductive nephrectomy after Camina?
Thanks, Michael. Thank you for the comments about the video. It was fun putting it together. It's slightly tongue-in-cheek, of course, but that's what you wanted from me, I'm sure. What were we trying to do as we put that talk together? It was trying to get a pragmatic approach to the, it's a pretty thorny subject, cytoreductive nephrectomy. We were trying to get a pragmatic approach to that, drawing on the lessons of the trial, the Carmina trial, and of our own experience. What were some of those observations? Well, O'Brien's observations about Carmina, I mean, many people have observed that the patients in the study were pretty high risk, a lot of disease in the metastases and a lot of metastatic disease. And I think that's evidenced perhaps by 20% of the patients never getting the systemic treatment. I tried to put the Carmina trial in a putative national context of how many cytoreductive nephrectomies one would expect to see in a country of France's size in a year. And so to give an idea of the case selection that there might have been, and also pointed out some issues that I saw anyway relating to missing data, particularly relating to pathological stage. You got to know your own results, and I presented our own results at Guy's, which suggest about 50% of the patients survive 3 years, which I think is reasonably encouraging for doing cytoreductive nephrectomy, and perhaps suggests we're selecting patients well. In our own practice, very few patients never start systemic therapy. It's 6% rather than the 20% that's often quoted. And I tried to introduce the concept of a good deferral of systemic treatment. Systemic treatment is pretty unpleasant, and I think many patients undergoing cytoreductive nephrectomy can get a good deferral of systemic treatment, a period of observation. And again, in our practice, that's about 25% of patients get a deferral beyond a year. So in summarizing the talk and the conclusions, I felt there was one question that urologists and oncologists need to get clear in their mind when they're seeing a patient, and that's what's the priority to treat? Is the priority to treat the primary, or is the priority to treat the metastases? Is this a systemic disease that's clearly presenting and surgery has no role, or is this a primary dominant presentation? And I think that's a critical thing to get clear in one's mind. And then in helping nuance that decision, so in helping nuance that decision making, try to introduce a traffic light where Carmina definitely tells us to stop. No knee-jerk reflex reactions to surgery. Stop and think. Then perhaps amber is work out the risk scores, get some IMDC criteria. Where are we with that? Really clear on whether we have widespread metastasis in multi-sites, and possibly consider a biopsy, because I think cytoreductive nephrectomy probably has a very minimal role in non-clear cell histologies, and certainly in sarcomatoid or Wilms. But I think cytoreductive nephrectomy in our hands is still considered in situations where there are equivocal metastases, where there might be serious complications developing from IVC tumors such as emboli or blocked cava, where a good deferral may be possible, and particularly in patients with a very large primary mass who have good performance status. And we think they still have a lot to gain from having the primary removed. So thank you for the opportunity to put the talk together. It's always good to give talks, isn't it? It really helped me crystallize my thoughts about it. And congratulations, of course, to the researchers who put Carmina together. It's a brilliant trial, but just trying to use the data from that trial to inform practice along with our own experience of the operation. Thank you.
Thanks a lot. So actually what you're saying is Carmina didn't take cytoreductive nephrectomy off the table, but it added systemic therapy to it, which is kind of the result we get from there. So you still do it, but you better select patients, and clinical performance status for you seems to be the main criterion to go with.
Performance status is one of those things, but I think, balancing the amount of disease in the primary and the metastatic burden really important, and critical to understand your own results. These are not easy operations, and surgeons who are knocking out these operations and causing mayhem by doing so, are not doing anyone any favors.
So, do you feel comfortable? Like challenging your own approach in terms of when you decided you didn't do cytoreductive nephrectomy, you come back after a while and you decide to do like a delayed nephrectomy, or is that something where you're like, no, this patient now is a systemic therapy patient and he's not going to get the kidney taken out ever?
I mean, it's a slightly different question, that, isn't it? The issue of deferred nephrectomy, and I don't think we know the answer to it. I know a lot of patients in the Carmina trial did have a deferred nephrectomy. We don't know whether it's beneficial. We think it probably is in the people who get a very good response, but I don't think we know the answer to that. It's the next question really in this area, isn't it? What's the value of resecting the primary once you've stabilized the overall picture? Yeah,
that sounds totally reasonable to me, and it's actually what we're doing too here. And I think you shouldn't give up on what you know, and there are some patients who really can benefit, and then we should just decide on an individual basis and maybe be a little bit more generous with systemic therapy. I still struggle which one to use, but that might be discussed later on in the meeting as well, which are the best options in first line setting, even with the primary tumor inside of it. We don't know, but.
Yeah, I mean, that was one of the things I drew out in my talk, was the evidence seems to be just behind the practice. We were using the interferon trials to guide practice in the sunitinib era, and now we're using the sunitinib trials to guide practice in the IO era. It just always seems to be a bit behind, the evidence is a bit behind the practice.
Okay. Thank you. That was very inspiring to hear two hospitals, how they are treating these patients. The next speaker will be Dr. Saeed Dabestani, who will talk about RCC follow-up, what, when, and why. Saeed is principal investigator in an ongoing international study, so maybe we'll hear something about that as well. Please, Saeed.
Good day, everybody. My name is Saeed Dabestani. I work in Sweden as a consultant urologist, and I'm very pleased to be here to join this panel today. So my topic was on the what, when, and why of follow-up, so which basically boils down to when all is said and done and the curative treatment is given to the patient, what happens next, and how do we find those that actually recur. And to just summarize the highlights of my talk, I discussed what type of imaging modalities we are using today and what the evidence behind it is. I also mentioned PSMA PET-CT, which it's interesting because it's showing some promise in detecting kidney cancer recurrence, especially metastatic disease. We don't know how that will develop, but it's interesting to mention. I then continued to review all of the major guideline updates because I felt it was important to give a real-world perspective on what the guidelines are saying and how we should be following these patients up. And that could be boiled down to that it's more and more becoming evident to follow up based on subtype of RCC, to have that in your consideration when you're thinking about the risk stratification of how big is that the patient's risk of recurring and within what time span. But also considering competing risks and more importantly, life expectancy when you determine on how long you should be following these patients. To this point, I discussed a newly published paper that looked at chromophobe RCC, where they could show that it was one of the largest cohorts that looked at follow-up for chromophobe RCC. And that if you were devoid of sarcomatoid features, if the tumor was PT2 or smaller, if there was no positive surgical margin or coagulative necrosis, what the benefit of that patient would be that they have a very, very small risk of any recurrence, and their follow-up could be curtailed after 2 to 3 years. Last but not least, I talked about future perspectives and the biomarker study that Professor Lund mentioned. And basically, it's a level 1B evidence diagnostic test study that is looking at a new biomarker that's found in blood and urine, which is, we've named it GAG score. And it's a clinical trial that's been reviewed by the FDA, and it's running now in, let's see, I think we're up to 16 countries in Europe and in North America as well. And it's basically using metabolomics to look at recurrence detection. And the preliminary pilot studies are showing very good promising results when it comes to the sensitivity and the specificity of finding a recurrence using blood and urine based markers. And the last point I brought up in my presentation is actually an interesting one, because we're seeing more and more neoadjuvant and adjuvant treatments being offered and being approved even now, quite recently actually. And that brings up an interesting question about how will the follow-up change if adjuvant is efficient, adjuvant treatment is efficient for these patients, especially the high-risk ones. And we don't know the answer to that. It might become more frequent because the follow-up will adhere to the study that did the adjuvant trial to begin with, or the follow-up will reduce because the efficacy of the treatment will be very good. That's kind of the summary of what I gave my talk about, and I hope you guys get the chance to see it. Thank you.
That was really great, Said. So you are also in the group of panelists who are making the guidelines for the EAU. So you have compared the different guidelines. Do you think that we should go in more selective, more individual guidelines for each patient in the future, or should we still stick to these boxes, how to follow the patients?
I think the key word is guideline. It's a guideline, but as a colleague who is also presenting today, who very accurately, in my opinion, said, you have to use your nose, Karim Ben Salah. You said this to me about follow-up, because it needs to be tailored to that specific patient's needs. So I think that the future of the follow-up regimens will be still boxes, yes, but the tailoring must be more precise in us as clinicians and as researchers in providing that the evidence behind the tailoring.
Hey, that's really great. Thanks a lot for this nice presentation and all the hard work you're doing on this. And I think that this is a really good point. A guideline doesn't mean that you have to follow it if the situation is not covered by the guideline, or you don't feel you should go there. That's a really good point. Well, we're going to come back in the discussion a little bit later, but we're moving on right now with Arnaud's presentation, Arnaud Méjean from Paris, and who else should be better to present about surgical management of locally advanced persons. He is the grand master of the Carmina trial and gave that to us. So I'm really happy to summarize quickly your awesome video.
Yes, good morning, everyone. When the organizing committee asked me to make this presentation, I really don't know if I should do it in a surgical point of view or in an oncological point of view. And I decided to do this presentation in an oncological point of view because I realized when I prepared this presentation how bad the prognosis of these patients with high risk or localized kidney cancer or high risk advanced localized kidney cancer are bad, very bad. And these patients have a very bad prognosis. But especially, that's the evidence is that we don't make any progress in 20 years, since the overall survival of these patients is roughly 70% in 2 years, and overall survival. And when you compare the study published by the Beldegrund team in 2004 and the study published in 2021, the prognostic is exactly the same, 70% in 2 years. So it's very bad prognosis. In parallel, what is very interesting is that the prognostic of patients with intermediate metastatic kidney cancer treated with nivo-EP, nivolumab plus ipilimumab, is exactly the same. But if you go back to the past, in 2004, the prognostic of this patient was 30% in 2 years. So, in other words, I think that oncologists have significantly improved the prognostic of these patients, where the surgeons have remained very static. And the worst part is that the surgery, as you know, is a very complicated, demanding, stressful, and thankless surgery. So I think, and it's my conclusion, that we really have to work on this peri-operative treatment for these patients. And I think it's really imperative, and that we need to work together to find the best sequences.
Okay, thank you. We'll continue with the fifth speaker, Maxime Tran, who will speak about active surveillance indication, risk, and benefits. So please, Maxime, the mic is yours.
Thank you so much. Thank you for this opportunity to talk. So my remit was to talk about the indications, risks, and benefits of active surveillance for localized renal masses. And I started the talk with the definition of active surveillance, which, as described by the major guidelines, as the monitoring of lesional behavior and delayed intervention if progression is seen. And the aim of active surveillance is obviously to delay any treatment-associated toxicity. I went on to discuss why active surveillance is such an important management option in our current clinical practice, particularly as the incidence of kidney tumor diagnosis is increasing year on year. And in fact, up to 47% of new renal tumors are now diagnosed at clinical stage 1, T1. And also a significant proportion of these new incidental diagnoses are benign tumors or relatively low grade. I think a very important question and highlight of active surveillance management is obviously that there have been several large studies, including analysis of the SEER data, and the DISRIM registry, which support the notion that active surveillance is safe. There have been guidelines recommending progression criteria to consider when to intervene. And ASCO have helpfully outlined 3 criteria, which includes whether if the tumor breaches the 4 centimeter size threshold, if there is a growth rate of more than 5 millimeters per year, and also obviously in the unfortunate event that metastatic disease occurs, which these large studies seem to show around a 1 to 2% risk. So I then finished the talk with, I think the most important for myself and my practice, this study looking at quality of life in patients treated with primary intervention versus active surveillance. And this was quite a large study of over 500 patients with over 250 in each arm, showing that by recommending or by offering active surveillance, the mental health of patients on the active surveillance arm is not adversely affected compared to patients offered primary intervention. I think that's something I worry about when I talk about active surveillance, and I think that was a reassuring study, and I think of good interest for everyone. Thank you.
Thank you. It was very clear. I just want to clarify. Do you have pathology when you are offering active surveillance, or don't you need a pathology? What is your opinion? Just you have the X-ray, or do you need pathology?
So in our practice at the Royal Free in London, is that we offer biopsy if it's going to change management of the patient, if it affects patient choice. So we discuss it with all our patients. Obviously, in the very elderly or comorbid patients where you're not going to, where you feel that intervention is not going to be of benefit, clinical benefit for these patients, then I think a biopsy plays no role. But in patients where if a biopsy may change their mind about whether they want active intervention or whether they want to risk having any kind of procedure, I think it's a worthwhile conversation. And similar to my to the other talk speakers here, I think it all has to be tailored to the individual patient, and it cannot be a blanket recommendation.
All right, thanks a lot. That was a great presentation, and I'm sure we're going to come back to the discussion again. Next in line is my good friend Alessandro from Italy, and as we all know, he does not only know about how to get your diagnosis, Maxine, but also how to do all different types of ablations, and I'm happy to hear his summary of the overview of ablations, which is hard to give a summary of an overview of different approaches, but I'm sure he'll manage perfectly.
Thank you very much, Michael, and thank you, everyone. I hope you can hear me well. My task, it's a great pleasure to be in this panel, and I want to thank the organizing committee for this great opportunity. Well, of course, it's very hard in 3 or 4 minutes to give an overview, but again, we are now dealing with the small RNA-MSs, mainly small RNA-MSs, and we have heard that, as we all know, these tumors have, in general, a low risk of progression and a relatively good behavior. And so basically all treatments are able to achieve good oncological outcomes in this setting. However, we have learned over the time how we should tailor the treatment, and we have to balance tumor characteristics and patient characteristics in order to pick the best treatment option. And where we all know that the gold standard for the treatment of these small tumors is definitely partial nephrectomy. On the other hand, we have learned how, at least in selected patients, elderly patient, comorbid patient with limited life expectancy, alternatives are possible. One alternative is active surveillance, as we heard from Maxine, but other alternatives are ablative treatments. Ablative treatments have been generally considered in this selected group of patients. However, there is a strong push in the last few years by mainly interventional radiologists to extend the indication to all patients with the clinically T1 renal tumors, irrespective of their age. While on the other hand, our guidelines, the urological guidelines, are much more selective, and they tend to identify this selected group of patients, elderly and frail, and to limit the indication to less than 4 or even less than 3 centimeter renal tumors. There are several ways to ablate renal tumors. Some of these techniques use freezing, mainly cryoablation. Others use heating, radiofrequency ablation, microwave ablation. There are also some rarely used non-thermal modalities, such as irreversible electroporation. Right now, the best approach is the percutaneous approach, although a laparoscopic assisted approach is possible. The percutaneous approach, of course, is really minimally invasive, can be done in a one-day procedure with just sedation, and it is definitely the way to go. The technical nuances and the techniques have been evolving, and now we are basically able to ablate all tumors, not only those tumors that are posterolateral, but we can definitely treat also anterior tumors. We can treat tumors that are close to the bowel because we are able to displace the bowel with gas or injection of saline in order to minimize complication. We can do pyeloperfusion in order to reduce the risk of damaging the collecting system. In general, cryoablation is favored for central tumor and larger tumors. Microwave ablation is also better than radiofrequency ablation for larger tumors. Complication rate overall is quite low in this using these techniques, mainly with the percutaneous approach. However, there are a lot of limitations. The first limitation is a lack of standardization, either for the indications, for follow-up, for definition of treatment success. Unfortunately, we don't have any good solid data regarding the best ablative treatment. There are no randomized controlled trials comparing them, and which is most important, we don't have any randomized controlled trial available comparing ablation treatment with partial nephrectomy. So we have to rely on systematic reviews and meta-analysis, and we just published last year with the EIKCS guidelines panel a statement, basically paper, where we came out with a conclusion that even the systematic reviews and meta-analysis frequently have poor quality. And what do we have from this? Well, what we know now is that definitely ablation has less complication than partial nephrectomy and can preserve renal function as well. On the other hand, the local recurrence rate is definitely higher. We have to take that into account, while cancer-specific survival seems to be overall the same. This is based on studies on T1A renal tumor. When we go to larger T1B renal tumor, we have to be even more cautious because studies from the SARE database have shown that if we treat these patients with ablation, we have even a 2.5-fold higher rate of cancer-specific mortality. So I don't think this is a good option outside institutional experience and randomized and clinical trials. What is the future? Well, can we build maybe randomized controlled trials? Well, I think it will be difficult. There have been many attempts to perform that, but the feasibility of these kind of trials is really difficult. And so I think that right now we have to stick with the evidence. We have to know that this is an alternative for sure that can have favorable perioperative outcomes. Ablation can have similar functional and oncological outcomes overall compared to partial nephrectomy for clinical T1A renal tumors, but we have to be aware that the quality of the evidence is very low. It is definitely less effective than partial nephrectomy for larger renal tumors, and we should be very careful to think about that for these patients. Why the recommendations are today limited? By the lack of comparative data with surgery. And I want to stress the last point. I think that biopsy should have an increasing role in this field. This year, for the first time in the EU guidelines 2021, we introduced a statement that biopsies should be performed not at the same time of ablation, but before, in order to really pick the best patient for each treatment option, including ablation. In my opinion, for example, high-grade tumors should not be the ideal candidate for ablation techniques. So biopsies should be used more in order to really better the selection of patients, also for ablative treatments. Thank you very much. I'm happy to receive questions afterwards.
Alessandro, really great overview on what's going on there. If so, you don't really can't identify the best patient for each and every ablation technique based on the poor quality of data. Is that what you're saying? And maybe as a second question after that, what's your most favored approach if you don't want to go for surgery?
Okay, well, regarding the best ablative techniques, well, what we know is that there are some tumors that have anatomical characteristics that can be managed better with this or the other ablative treatment. As I said, for example, larger tumors should be managed best with cryoablation or microwave ablation, while radiofrequency ablation is definitely inferior. There is evidence that freezing is better than eating on the collecting system. So when we have a central tumor or a tumor that reaches the collecting system, then you should favor cryoablation. Regarding the second question, well, of course, it's an important question, and we all spent a lot of time in our clinical research time to try and define which is the best option in a non-surgical treatment. Well, it's really hard to say. I think that right now we should really tailor the treatment for each patient. We should take into account patient characteristics, morbidities, and also is will to receive some kind of active treatment as well. There are several patients with more renal tumors that are elderly that are really happy to just follow the renal tumors over time, at least in the short-term period, to really realize what's the behavior, the clinical behavior of the mass, and then make a decision afterwards. And finally, I believe, as I already said in the conclusions, that biopsy is the future. In this patient, when I have a patient that is not an ideal surgical candidate, but still have a decent life expectancy, I really think that the biopsy can make the difference and can help us a lot to define the best option.
I just have some questions for you as well. Are you performing this ablation therapy after discussing the patients on a MDT?
Yes, of course, we should always discuss this kind of patients in MDT. The current issue, I think that, as you know, most of these procedures are done today by interventional radiologists. Mm-hmm. And unfortunately, interventional radiologists are not frequently involved in MDTs in several countries and in several institutions. I think we should we should make a change to this and really involve them a lot more. And that will also help to increase their knowledge of renal cancer, because one of the issues with the interventional radiologists is that they are very good technically, they are technically very good, they can do excellent, amazing things, but they don't know much about really the behavior, biology, clinical behavior of renal tumors. And sometimes that leads them to really push the indication beyond the limit, in my opinion. So, I mean, this should be, in the field of localized renal tumor, one of the future goals, also to try and involve interventional radiologists more in our discussion, to increase their knowledge about the disease, and this way to really involve them in treatment and use them to improve the treatment of renal tumor. Because I really believe that some of the small renal masses we deal with can receive an effective treatment also with the ablation.
In our institution, we have the radiologists participating as well, because we are discussing whether it should be a nephron-sparing treatment we should offer the patient. So we take them down in the outpatient clinic after the MDT and discuss ablation therapy. Just to clarify how we do it. What about are you performing these cases as day cases? So the patients come in the morning or go home in the afternoon, or what do you?
Yes,
what is your experience?
I have to say, I generally do perform biopsies myself, but also at my center, ablation, mainly radiofrequency ablation and microwave ablation, are performed by interventional radiologists. So yes, generally it's a one-day procedure. We try to perform the procedure early in the morning and discharge the patients in the late afternoon after, of course, check of vital signs and some blood work.
Okay. Thank you so much. I think I'll pass the mic to Michael for the next questions.
Just maybe to stay a little bit in the field, Maxine, so what makes a patient, or can you comment a little bit on the differences between active surveillance, watchful waiting, and the triggers for intervention in those patients, and how you communicate about the anxiety and the issues that patients might have because they have the tumor inside of it and nothing is done on the active surveillance. Do you have anything about that?
We have a quite clear distinction between active surveillance and watchful waiting. So watchful waiting is when we wouldn't monitor a lesion. So in these patients, we would only scan them if they develop symptoms, and we would only intervene if they develop symptoms. Whereas active surveillance, intervention is always an option, and that can be triggered if there were any of the red flags, such as the recommendation from ASCO. So if there's a rapid growth rate, change in characteristics, or if the patient decides, changes their mind and for their own peace of mind or anxiety levels that they would like to change into primary intervention. And these are, this is all part of the patient consultation whenever we get referred any patients with small renal masses.
Do you have any patients who are not happy with active surveillance when you offer it and are like, hey, get it out of me?
Yeah, we do. So that's also, it's kind of a evolving consultation. So when we discuss our patients at the SMDT and it's a small renal mass, what we usually, the SMDT outcome would be suitable for all T1A options. And that would include a period of initial active surveillance, biopsy, or primary intervention, which would be surgery. And we discuss all those options with our patients.
Right. Tim raised his hand, and I'm pretty sure he wants to comment on that. You're still muted, Tim.
Hopefully not muted now. Great. Maxine, I have a question about the access. Obviously, we do it. Do patients sign consent that they are following a treatment plan? Consent's one of those odd things, isn't it, where people consent because there's a procedure being done rather than a course of action being taken. And I just wondered whether it would be important for people to sign consent that they were aware of the pros and the cons of the approach that they're following.
That's a really good question, Tim. I mean, I guess if we are using it as a management option, then I don't think it's unreasonable to ask for consent. And we don't do that at present. I mean, we document everything obviously in our consultation letters that we've been through all the options, and the patient is happy, with the management option of an initial period of active surveillance. I guess this has kind of come to the fore because of COVID, and a lot of our patients have had to have a period of initial active surveillance because of the restrictions on what we can ordinarily offer. I mean, our practice has shown that they've not come to any harm, and they've all been quite understanding about that. Yeah. Okay.
I just wondered what panelists around this call tell. I mean, what patients are worried about in surveillance, isn't it, is tumor escape and being unable to treat. I wonder what people around this call estimate the risk of tumor escape is in people they embark with active surveillance. I mean, what percentage do you put on it? I know what percentage I put on it, but I just wondered what people around the call what percentage they put on the chance of there being inadvertent tumor escape whilst on surveillance. I'd say it's about 1%.
Yeah, based on the literature, it's the 1 to 2%. That's what we have from the largest trial, as Maxine.
Yeah, I agree. Yeah.
So I actually don't do any active surveillance. I do watchful waiting or ablation in patients. And I don't think that the active part is something that patients really appreciate, especially after you did the biopsy and then they know they have cancer. And that's a little hard to handle. And the biopsy kind of helps us more to push patients towards surgery when it's unclear what we want to do, rather than keep them from surgery on active surveillance. And at least the South German patients really don't feel comfortable having cancer in their body and nothing being done. And that's when we bring in ablation therapy usually. So I actually don't have a lot of patients in that situation. And I do think that the metastatic potential of small renal masses is way higher than we have. So the question is, what's the life expectancy of the patient that we're seeing? We don't really discuss about that. We only say he's frail for surgery instead of thinking about life expectancy. So if you have a patient who is 90 years old and is running up the Himalayas, he might be a candidate for surgery, where much better than somebody who's 75 years old and can barely walk anymore because he is sick of anything. Then we wouldn't do anything. We would not intervene, even not with imaging. Curious about the other thing.
But you must have patients, Michael, for whom treatment can't be administered at the time things are diagnosed. I mean, these scans are often done on ill people. So treatment of the small renal mass is completely out of the question at the time they're diagnosed because the patients are ill. And so they enter a period of active surveillance whilst they recover from their primary diagnosis. So you must have patients who have a period of 6 months where they're getting over the primary illness before you come to treat the small renal mass, surely.
Yeah, but we wouldn't do that as an active surveillance. It's not like a protocol we would follow. We would say, hey, if this guy is still around in a year, send him over again if he wants to come back. That's more what we do. But we wouldn't put them on an active surveillance scheme where you plan after 3 months, after half a year, after a year or whatever to do any kind of imaging. I'd rather have it clear out there what I'm going to do for the patient. I'm either going to treat him or I'm not going to treat him. And ablation, you can almost do in every patient. I mean, there is actually no limitations.
Well, Michael, I agree with you that biopsy can be helpful also to select patients for surgery. I mean, there are some patients with really small renal masses that have aggressive disease. And in these cases, I think that when we know it's high grade, that we should probably do surgery anyway. That's my view. On the other hand, anyway, we discussed many times, I think that when you know that it's a really low grade tumors, and let's remember that in the future, we will have better information from genomic signature. And we know all the great work that Samra Turajic is doing in this field. And we are trying to test also, for example, in the European active surveillance trial. And one day we will be probably able to really pick those tumors that have a signature that really states that they will probably never progress. So with this tumor, you can do whatever you want. And at the end of the day, the oncological outcomes, at least in the intermediate term, will be good. So that's my point. I think that biopsy can really help in many, many cases, except for those that are clear surgical candidates.
That's a really good point. And I think we need to, in general, it has nothing to do with small renal masses, but with kidney cancer in general, we need to find ways to better characterize tumors and their behavior in the future. So it might be that you have a really big tumor with T2 who's never going to metastasize. That might play into Saeed's presentation about surveillance as well, where you're like, hey, this guy probably doesn't need a lot of surveillance, where a patient with a 3 centimeter T3A that behaves aggressively, which would play into Arnaud's talk, might actually need some systemic therapy right away. So I think there is a lot we can do. And unfortunately, Summer is working in London and not in Munich. And so we don't know what she can tell about our patients. It's still a little bit hard depending on your path. But to move things on a little bit, maybe for Karim, now we decided we're going for surgery in the patient, and we're still in the field of a small renal mass. Let's say it is for sure smaller than 7 centimeters. What do you think are the best options for the majority of the surgeons to perform in a patient like that? Which means, does everybody have to use the robot? Where are the limitations there? Is there like a socioeconomic aspect to it? And what's your recommendation to treat a small renal mass?
This is a tricky question. Most of the data we have show that morbidity is decreased with the robots. So without impairing the oncological outcomes. So one would be tempted to say that as soon as one could, you should use the robot. However, it's not the way it is. Some institutions don't have the robot, although in Europe now most of the hospitals are fully equipped. But sometimes it might not be easy to access the robot. So it has to be, the decision has to be taken at every institution according to the equipment and to the skills of a surgeon. It depends mostly on the experience. It's been shown that the learning curve of a robotic partial nephrectomy was quite long. So if you have a complex tumor and that you feel that the open approach might be better, then go for the open approach. But as long as, if you have quite a good experience with the robot, my opinion, but I use the robot quite a lot, is that patients are better served by a robotic partial nephrectomy. However, it's not a crime to do a lumbotomy to remove a small tumor. And I remember the discussions we had in the recommendations panel. For now, official recommendations that you can remove the tumor the way you feel mostly able to do it.
I think the main message here that I hear from you is remove the tumor, don't remove the kidney. And either tool you're using is the best one, right?
Yeah, sure. For now, I strongly think that was the purpose of my talk. Do we really need a randomized trial to find out that partial nephrectomy is better than radical nephrectomy? I don't think so. I think that we have enough observational data to state strongly that we should spare the kidney, although we are not totally sure of the benefit. But yes, that would be the message: spare the kidney whenever you can.
But the next question I have for you is totally unfair. You were not prepared, and you know that I'm always a little bit pushy in there. So, given the data that we should not do robotics in adrenal tumors or in cervical cancer anymore because of a worse oncologic outcome, does that give you a little bit of a pause in deciding what to do in a young patient? Not being totally sure that we have a trial that ever proved oncologic equivalence of laparoscopic approaches to the kidney?
Okay, so this is another tricky topic. We have to say that from observational data that there are very uncommon patterns of recurrence with laparoscopy and robotic approaches. We don't exactly know why, and we've seen this as the techniques were spreading. However, there is a very beautiful study that's been made by a European consortium, and I'm part of it, so I know it's in the way of being published. It's not published yet. That shows that if the pattern is different, the overall survival is comparable between open and robotic approaches. In the end, in my opinion, it all comes down to the biology of the tumor and not necessarily the way you remove it. And what we should be really careful is not to make any breach into the tumor, because to have negative margin, which is the mainstay of oncologic surgery. So once again, no matter how you do it, you really have to has as a primary objective to completely remove the tumor without any trauma. And the biology of the tumor will make the rest.
I think that's a really important statement, and it brings us back to like all of us struggling with the biology of kidney cancer. We don't really have an established biomarker. We don't really have a good way of analyzing the progression rate or potential of any given lesion, and that's complicated. And so far, we can't figure it out prior to surgery. We can't really figure it out during surgery. So there is nothing more we have. Arnaud, maybe you want to chime in a little bit here and think about like locally advanced small masses. Is there a different approach to that, or is size the limitation of kidney preservation, or even of perioperative therapy once it established?
Oh, there are so many questions in one question. What I can say is I think really it's really a question of interpretation of CT scan. I mean, and the time you have with the radiologist to interpret the CT scan or the MRI. I think we really have to take maximum of time on the computer to see exactly what happens concerning the tumor. So I mean, to respond to a question, what is my limits to make a nephron-sparing surgery? Even if I have a PT3A, I think you can do a partial nephrectomy for PT3A tumor, depending the surgery you are doing. Concerning the locally advanced tumor, I think there is at the present time no indication and no recommendation on the therapeutic and on a systemic treatment before the surgery. But sometimes I really think that we really have to try to decrease the tumor and try to decrease the thrombus. Certainly the new combo, I mean with IO and TKI, will certainly change the possibility for us to operate these patients after a systemic treatment. I know there is no recommendation at the present time, but I think that there is so many trials are ongoing to try to find the good sequences between the systemic treatment and the surgery. And for example, I can give you some examples that we have for a patient with a so important tumor, and especially on the development or lymph node around the pedicle. And in this particular case, with the neovascularization all around the kidney, the surgery was certainly very difficult. And we decided for this patient after a biopsy to confirm that it is a clear cell. We are doing a treatment using pembrolizumab and axitinib. And we're a couple of patients with this treatment with an impressive decreasing of the tumor, and also for the thrombus, for example, or for the lymph node. And after the treatment, we can make a surgery. I know that the surgery could be difficult after this treatment, We share some cases with the French team. Geraldine Pignot is collecting all the data for these patients, and we discuss some cases with Karim Ben Salah that he has expertise as I did. But sometimes the surgery could be very difficult, I know that. But I think for the patient, it's certainly the way to decrease the development of the tumor and to increase the prognosis of these patients. So I don't know really if the treatment has to be made before or after the surgery, or if the treatment has been made before and after the surgery. We don't know. Nobody don't know. But I'm sure that it is the future for these patients, and I will be very happy to share with you this possibility to work with.
Yeah, that sounds great. We have a question from the audience here that they're asking, if you have a patient who had a complete response on systemic therapy, as a neoadjuvant approach, would you still go in and do surgery on the primary tumor?
I think really at the present time, it is not possible to do that. And I think it's very dangerous because we know that it's an option, exactly as we have, for example, for the testicular seminoma, or when we remove, I know that it's a very small number of cases, but if you make a removing of the lymph node, sometimes you have mature teratoma inside the lymph node. But I don't think it's a good option for the patients with kidney cancer. And really, we really need more data to adopt this sort of strategy. So I mean, really, after a systemic treatment, it's certainly necessary to make the surgery at the present time.
Maybe Tim, you want to come? Oh, Karim, you raised your hand. Maybe you want to say something again.
Yes, just to add a comment from the French experience, as Arnaud was referring to. We collected data on about 13 to 14 patients who had a metastatic disease and who had been given IO for several months. And the messages, as Arnaud was saying, is that surgery can be very difficult, mostly because of inflammatory reactions. And the second message is that we have up to 1/4 of the patients whose tumor were totally necrotic, no sign of active tumor. So we don't know, we have no clue whether it will remain like this, but this raises some questions. The one you were asking, should we really do surgery in those patients? We don't have any biomarker, nor do we have any insight on the imaging to know if the tumor is going to be completely necrotic, but this should be an issue discussed with the patient, particularly if the surgery is supposed to be difficult.
So I would like to point out to the audience that please write some questions if you have some burning ones, and we'll try to ask the panelists. There is one question from the audience, Tim. I think you should try to answer this. What do you think about patients in sunitinib arm in Carmena trial who went for surgery after treating with sunitinib? Have you any comments to this?
It's an extension of the previous question, isn't it? Yeah. Those patients that Arnaud was talking about and Karim was talking about, whether you've had sunitinib or you've had a combination of IO, TKI, we're not really sure what to do. And those are moments where there is uncertainty. Those are moments potentially where randomization can work, aren't they? Because particularly if the surgery is going to be difficult. But I can understand, Arnaud knows the Carmena trial better than I do. I can understand why the patients opted for nephrectomy in that situation. I can really understand it. I think I would have done if I'd had a spectacular response to sunitinib and had the opportunity to have the primary out. So I can understand why they made the decision. A lot of these questions, you can end up saying there should be a trial. It is an important question, isn't it? What should you do after a very good response? And we don't know the answer to it. And unless we do a trial, we never will.
But could you please comment? Because I think as urologists and surgeons, we have a problem that we should have these studies for many, many years. And there is maybe 400, 500 patients included in this in many centers. Mm-hmm. And the oncologists, they can have trials with thousands within 1 or 2 years. Why is that? Of course, it's the pharma, but what is your opinion about that as well? Are we too busy in the clinical work?
Is that a question for me, or?
Yeah, it's a question for you because you have been involved also in these studies.
Yeah, I think it's a good question, isn't it? I mean, in pediatric oncology, I think 90% of patients in pediatric oncology go in a clinical trial. I mean, it's absolutely astonishing. It is just what happens. It's expected, and that's what happens. And I think it's redefining expectations. I think that where there are elements of uncertainty, then people should go in trials. But how do we change that culture? I'm not sure. I'm not sure how we change the culture. I mean, it's interesting. I mean, Karim talked about the radical nephrectomy, partial nephrectomy question in his summary. In fact, the NIHR, which is the body in the UK that funds most trials work, has actually just commissioned bids for a trial of radical nephrectomy versus partial nephrectomy in the small renal mass. So, I mean, Maxine is one of the people who's put a bid in for that protocol. So it is, I mean, the NIHR is trying to push for those things to be studied. And I'm glad they are.
I think we have really to work on this tradition and try to change it, because it's a tradition also that we should be more involved in clinical trials. I think so on the long run. I just want to go back to the partial nephrectomy, Bensela. What do you think is the most important? Is the preservation of function or the oncological outcome when we are doing this partial nephrectomy? You say save the kidney. So why are we saving this kidney? For what reason?
For what reason? Well, you asked me what's the most important. I guess it's the oncological outcome, and all the data we have point in the same direction. It seems that removing the tumor is not harmless compared to removing the whole kidney. So I think we're good on that point. So the second one, why should we spare the kidney? Because we might need it. One never knows. And we've made tremendous progress. And now partial nephrectomy, particularly if done robotically, is really straightforward with very low morbidity in major centers with high robotic volumes. Major complication rates is less than 5%. Most of the patients go home the day after. So I'm not sure that the toll that patients have to pay is not worth it. And I would say all the lights are shining towards partial nephrectomy. And if it were me, I don't have any randomized trial to support it, but I'd rather have my kidney spared, because you never know, I might need it during the 20 or next 30 years. So I think for now, based on the evidence we have, maybe when the English colleagues will have completed their trial in 15, 20 years from now, we'll have a better answer. But for now, let's spare the kidney.
Tim has a comment.
Yeah, I mean, you make the point well, and the challenge is recruitment. But I don't think people feel as equipoise about an exophytic T1A mass. I don't think people are looking for randomization on that. But you must accept, Karim, there there is a point at which it becomes not sensible to try because of the risk of margins leaving tumor behind and massive complications. And, you know, as tumors get bigger and more anatomically complex, there must be a moment where even Bensalar decides, no, we're not going to do this. And I think it's finding that point of, that point of equipoise, isn't it? I would say it's for large tumors and anatomically complex, centrally placed smaller tumors. I think there is potential serious risk to a patient from surgeons trying things that are probably not warranted.
I agree, but this is something we all experience in our daily lives. It's not because you can do it that you should do it. Well, so maybe you can give us more insight but with the randomized trial, if it were me, I would have a very hard time including a patient who has a 2 centimeter mass that I know I can easily remove by robotic assistance or no matter what. So it's a great challenge, and I'm happy you're embracing it.
I'm not so sure.
We don't know whether they'll fund it. I mean, the NIHR has commissioned the bids, and that usually means they are interested in funding it rather than asking for bids. But we'll see. Will you still be practicing in 15 years' time? Yeah. I'll be playing golf and be skiing in France, hopefully,
and donating kidneys, maybe. I mean. I don't think that, if you think about it, somebody gave us some organs twice, and there's a reason why we have that. If we look at the other tumors, you wouldn't remove the whole organ. Why would you do that? You just remove the malignant tissue, and we haven't shown that removing more than that is beneficial in any disease. So why are we starting that discussion in surgery? And I think it's only because we're like, oh, that is so hard to do. We don't take the next step and are like, hey, let's train people to do that so that partial nephrectomies are becoming a standard. It gives me pause, for example, if somebody says, hey, this is too centrally located. I personally think those centrally located tumors are most of the times easier to do surgery on than some of the peripheral ones that might be really big and adjacent to other organs and infiltrating into the fatty tissue. So I don't think that there is a clear way of thinking here that we can guide it, but we actually have to be better in training people to preserve kidneys. We're losing too many kidneys without a reason. And I doubt that we're ever going to have the power to show in a randomized prospective trial a meaningful difference in cancer-specific survival in those patients. It needs a huge number of patients. We're talking 3,000 patients to show that difference with 15 years of surveillance. But the patient is sitting there today. He needs a recommendation today. And for me, actually, I don't want to harm him taking out more than I need to. It might be a little bit provocative there, but I think some of those discussions should go there. Now, let's go a little bit back into our presentations, and I think we need to talk a little bit about Saeed's approach to surveillance and how to do that. So Saeed, if you could just summarize a couple of things there. What is the main principle of a standard surveillance in a localized disease after a partial nephrectomy? Which are imaging modalities that you would recommend? Which are ones you wouldn't recommend? And is there something coming up in the future like fancy PET scans or whatever? You're still muted, Saeed.
I thought, oh, there we go. Better? Can you hear me, guys?
Yes.
Can you hear me now? Good. So it's a good question. Well, the basic principle for the follow-up is that the more years you follow the patient without any signs of recurrence through imaging, the less frequent the imaging should be. That's what all the guidelines are saying. Specifically for partial nephrectomies, the only guideline that uses that as a stratifier for patient follow-up schedules is actually the AUA guidelines. The other ones basically say that define the risk of recurrence based on the tumor biology together with the tumor size, and not just what type of surgical technique was used. When it comes to the imagings, well, we looked at the clear path to which imaging to choose is based on where the most frequent sites of recurrence occur. And that's what always brings us back to the imaging of the chest and of the abdomen. Talking about the chest to start with, CT scans, I think, should be the standard of care now. We know more about radiation exposure. We know how to do low dose imaging scans, and you get more granular results with a CT scan as opposed to a chest X-ray. Interesting enough, the same, just to take the opposing view as well, the chest X-rays, turns out that those that were followed with chest X-rays and then compared to those that were followed with the cross-sectional imaging, when we looked at this in the Recur consortium, we couldn't see any difference in terms of recurrence rate detection and or survival differences. I mean, and that basically means that it seems that it doesn't matter. But thinking ahead, thinking about the future, thinking about potentials for future diagnostic or prognostic biomarkers, thinking about the potential for adjuvant treatment, I think that finding these small undeterminate granular lesions in the lungs are important, even if we cannot for sure say that they are metastatic disease. And finding them would mean that the patient would be in a situation where they could be offered future adjuvant treatment. When it comes to the abdomen, that's where, and also I'm just talking about the major sites, but when it comes to the abdomen, we have the benefit of adding to the CT scan either an ultrasound and or an MRI scan. And this was a very nice systematic review slash PhD thesis that was done by one of your students, Professor Stoller, who looked at the sensitivity and specificity of these two modalities. And just with it's a very nice thesis. It's very long, but so I won't go into the details. But in summary, the use of an MRI as an auxiliary or ancillary method of looking at renal masses or suspected local recurrences primarily, actually. They have very good results both for MRI and then contrast enhanced ultrasounds. But the main point would be that you get good results when you have centers that have high volumes of these assessments being performed. I hope that answers your question about the modalities and my perspective on them. And the follow-up.
Before I take Tim, who raised his hand again, I want to extend that question a little bit to Maxine. What kind of imaging are you using for patients on active surveillance? Are you doing chest scans also? What kind of modalities do you use for the primary tumor? How do you schedule this active surveillance?
So we use a combination. So some patients get MRIs and some patients get CT scans, and that is usually based on patient characteristics as well. So if they're a fairly young patient, then we would err towards MRI scanning. So I touched on the talk with the in regards to follow-up, and ASCO have made some recommendations which we don't tend to follow because they seem to be quite intense. You know, given most studies have shown that renal masses tend to grow quite slowly anyway. We tend to do an initial scan at 6 months and then a further scan in a year. And then that's modified, obviously, depending on the patient and lesional growth. We don't tend to use ultrasounds because personally, I don't think it's of much use. It's so kind of inter-operator variability, so it's so large that it's not really of benefit for us or the patient.
And are you including the chest or just the abdomen?
Only the abdomen. So only in I'm talking generally about sporadic patients. Obviously, are patients who've got genetic disorders such as HLRCC, where we know this, the metastasis does occur even with sub-centimeter lesions. They get a CT chest as well as an MRI of the abdomen on a yearly basis.
Okay. That's a high risk patient.
Yeah, that's why we would monitor them that way.
I just to kind of comment on the whole aspect of, because the ones that do active surveillance, they're per definition low risk cancers. And we're looking at this through the Recur Consortium, and I was looking at this yesterday actually. And turns out that the numbers needed to detect one recurrence is with imaging of the chest in these low risk patients is about 359. So you need 359 imaging performed to detect one recurrence in the chest in these low risk patients. That's a very high number, and I think it does not justify an imaging of the chest.
Well, if I can say a word, I would say that, in my opinion, that's true. So definitely we should minimize the use of imaging of the chest. However, it's not bad to have at least one imaging, to have a baseline, in order to be able to follow up the patients better afterwards. So I agree with we don't need the routine annually chest CT, and chest X-ray is probably useless, but I generally tend to get a chest CT done while the patient is getting the chest of the CT of the abdomen during surveillance, at least at 1 year, in order to really have a baseline, or even at a baseline scan if possible.
Tim, did you have a comment?
It was a question for Saeed, and it was about surveillance of the contralateral kidney. And so imagining I'm a 58-year-old patient and I've had a radical nephrectomy, what does the evidence tell us about the surveillance of the contralateral kidney, whether it should continue forever or whether there's a moment when it can stop? And what is the time frame of the development of contralateral tumors in people who've had renal cancer on the other side?
The rough estimate number is 3% or just below 3% will have a recurrence in the contralateral kidney. Usually these recurrences occur later, beyond 2 years definitely, and I think half of the instances is beyond 5 years. And the big question is that a metastatic disease in the contralateral kidney, or is it a de novo tumor in a patient that has cellular instability? We don't know that. But the answer to your question is more pragmatic and empirical than it is evidence-based. And it's that if you use an MRI or a CT for imaging of the kidney side that you did a local resection on, you'll get imaging on the other side. I mean, that's a given. And then for ultrasounds, if your center uses contrast enhanced ultrasound, it's actually good practice even for the sonographer to move the ultrasound device over to the other side.
So I have another question about surveillance in general. So we're relying on like historical data that we have from some centers who did surveillance. Given the fact that there is no structured surveillance and we have a lot of patients being lost to follow-up, and maybe even some countries not doing anything in patients rather than ultrasound after a while, how solid, how reliable are the data we have? And should we try and set up something for the future to get a better understanding of what really happens in patients? Or do you feel comfortable that the data we have are sufficient for future recommendations?
Excellent question. All of the evidence so far is based on retrospective data. And the collaborations that have retrospective data, there are national ones and then a couple of international ones, but all of them are retrospective, and that brings in a bunch of biases. To get the granular results, you especially for the low risk patients, where you would potentially benefit the most by reducing the number of imaging for the certain patients, you need really big volumes of subjects that are in these databases. So, there is, yes, I think that there is a need for a structured prospective approach, and to that end, there are a couple of projects that are about to start. One will be in the UK most likely, that will be looking at the intermediate and high risk patients and a structured follow-up program based on the evidence that we do have now. And then there's a low risk one that is being funded through the EAU Research Foundation that hopefully when COVID is over will start. Right now it doesn't make much sense because most of these patients, there is no room for academic research in connection to the clinical follow-up of these patients.
Okay, thank you so much, everyone. The time has now it's 12:30 o'clock. So on behalf of Michael Staeler and myself, I would like to thank all the speakers and panelists for their video presentation and their hard work with this. And I also thank you for this debate. And again, we would like to remind the audience to put up questions so that it could be a more lively session. And I hereby close this session. Thank you for attending.